Hi everyone, thanks for joining us tonight for the cancer conversation. So sorry we've been a little bit behind today. Dr. Roney unfortunately isn't feeling well. Normally he would have started us off. So I just finished up with patients and I'm happy to be jumping in and joining you now. So without further ado, I guess I'll share the PowerPoint we have for today. Today we'll be doing a question and answer. We've been collecting questions over the week that were sent in on social media and to our website as well. So we just collected some of the main questions that people had. And then at the end, if there's time, we can take any Q&As from the chat as it's been coming in. So just as an overview, if it's your first time joining us, we are the Center for New Medicine and the Cancer Center for Healing, two practices under one roof. The Cancer Center for Healing for those that are undergoing diagnosis or treatment or surveillance for cancer, and then the center side for basically everything else, including early detection for cancer. So I work on both sides. Dr. Roney, my colleague here, usually leads the cancer conversation. He's worked in the integrative medicine field for over 20 years. He's a chiropractor by trade, but guru in all things health, especially functional gut and nutrition. Does a little bit of everything, and he's the director of the Cancer Center for Healing. So you'll see him down there on the IV floor all the time. Myself, I'm a naturopathic doctor licensed in the state of California. Before attending Bastyr University in San Diego, where I got that degree, I attended Princeton, studied molecular biology, and I love integrating what I learned there into what I do here. There's a lot of overlap, obviously, in molecular biology with what's going on in cancer and cancer biology. In addition to that, I like treating women's health, gastrointestinal conditions. I did some training through Dr. Dale Bredesen in neurocognitive health too. And one big thing to consider is that cancer isn't happening in a silo. At the same time that you might be going through a diagnosis or treatment for that, you have your whole medical history that's either directly contributing to the cancer process or is happening at the same time, and we need to help you be supported during that. So we're taking a look at the big picture. So this slide, I guess, is going into detail on everything that we're capable of doing. We're one of the largest integrative cancer treatment centers in North America. We have practitioners from all backgrounds that have particular experiences and expertise in different cancer types, disease states. We have direct personal relationships with many different cancer testing companies, including the some listed here on this slide: RGCC, Fulgent, Guardant. Those are looking at circulating tumor cells and circulating tumor DNA, which we might go into more detail about later. American Metabolic Labs looks at different enzymes, hormones, tumor markers. It can be used in healthy screening to see if the environment of your body is more conducive to growing a cancer or could be indicative that there's something brewing. Menarini is another circulating tumor cell test. And then a lot more. So the idea is that we want to do enough testing that we know what you need based on what stage in your journey you're in. Picture of our location. We're in Irvine, California. And I wanted to comment on what it looks like on the center side if we're talking about comprehensive early detection and overall health testing. So this is a program that we've been working on for those individuals that come in and say, I want to spend a couple days to a week here to do all the testing I need to see what's going on in my body. Looking at energetically, is there any evidence of dysfunction in any of my acupuncture meridians? What's my nutrition status? Do I have any toxin or heavy metal burden? We can look at your blood under a microscope and see if there's any patterns indicating all sorts of health correlations and indications. We can do parasite testing. Parasites can suppress your immune system and directly cause nervous system dysfunction, heart issues, gut issues. And we've never found a patient that doesn't have some burden of parasites, so it's helpful to know if that's going on and to what degree, and then routine screening for cancer in general. So you see on that bottom of that day 1 slide, the Cologuard test. That's a stool test that's FDA approved for cancer screening. It's recommended for everyone 45 years or older. For those that have a stronger family history of colorectal cancer, we might even consider doing that or a colonoscopy earlier. Unfortunately, we're seeing a higher rise in colorectal cancer in particular, but several different kinds of cancers in younger individuals. Then you might get blood work on day 2 after you've met with the doctor and the blood test has been ordered. Some more energetic questions and tests, and then we go into some of the treatments. So some just general healing treatments, nothing that's going to have too long-term of an effect, because one treatment or a week of treatment wouldn't quite be enough to really make, depending on the severity of whatever we're helping you with, it would be more of a taster. So we could see if you were to come back for more long-term treatment, what we'd want to prioritize based on your experience with these tests. So this is the kind of program we'd want to implement. If you want the full workup, that's a little preview of what that could look like. So when it comes to cancer prevention and care, we like to organize our thoughts and how we treat you based on the 4 pillars. Number 1, which happens at the beginning for sure, but also happens frequently during the treatment process, is comprehensive testing. We want to know if there's imaging evidence of disease, if there's circulating tumor cell or circulating tumor DNA evidence of disease, so that when you're undergoing treatment, we can see what direction the treatment's moving in. Tumor markers would be part of that panel too. And then on imaging, of course, you want to see things shrink as well. But then there's also blood work for what's going on with you hormonally, what are some root causes. There's nothing we can say, this caused your cancer. We can never know that, it's a black box. But there are certainly parts of your history, toxins we can find, like mold, heavy metals, plastics, that we know suppress your immune system. We know can make cancer cells less susceptible to the treatments that we're giving them, meaning reducing chemosensitivity or making the chemo less effective. So one that Dr. Keneally's been doing a lot of research on and sharing with me has been phthalates and other plastics and chemical toxins, that when there's higher phthalate burden in the body, there's lower likelihood that the cancer will respond to the chemotherapy. So we're always looking for how do we optimize this treatment? Why is this treatment not being as effective as we want it to be? And what's the next best treatment for you based on the testing that we're getting? So that's pillar 1, comprehensive testing for root causes and how effective is your treatment and what's the best treatment for you. And then pillar 2, what is our anti-cancer strategy? Sometimes we need, Dr. Roney likes to call it the atomic bomb, chemo, radiation, surgery. And a lot of times one or more of those is going to be integrated into a plan, because those really do have a lot of merit at reducing tumor burden and getting good control of disease. But then naturally, how are we adding oxidative stress to the system? So that means, how are we getting enough inflammation that we can help to kill cancer cells? And then how do we support root causes too? That's coming in pillar 4. So getting rid of mycotoxins, reducing environmental toxic burden, virus burden, emotional work, that should be on this list truly. We always find an emotional component, whether it related to cancer diagnosis or chronic stress contributing to cancer. We want to address that. Maybe you're stuck in an emotional pattern from something that happened in your childhood, or maybe one of your parents went through something traumatic and their experience with that has carried on to you, and it's a burden that you carry now. So that really needs to be addressed with every patient. And then I skipped over pillar 3, but immune boosting. Some of the immune boosting therapies that we have overlap with the natural cancer treatments that we have. We're going to go over some of them today based on some of the questions I saw that came in. So that would be something like vitamin C. It really activates your T cells, keeps your immune system strong, but some other therapies as well. So we're always going back to the 4 pillars because it's a lot of information. You're getting a lot of tests. There's a lot of recommendations for therapies. There's a lot of supplements. There's a lot we're asking you to do at home. And so organizing it this way helps helps you categorize what we're doing with each recommendation. So with that, I think we'll go into some of the questions. I have them on this slide over here, so I'll read them out to you, let you know what the question is, and then give you an answer. So the first question that came in is, what's the best screening to do before age 40? 40, Dr. Kenny likes to say, this is when the warranty's up. Before 40, you still have a lot of stem cells. Your tissue is capable of regenerating and healing a lot better. And then as we get older, we have lower stem cells. We don't produce as many proteins. Some of our glands, our hormone producing organs, start to shrink. And so we don't have as much protection from those things. At that point also, we have a higher burden of exposure to environmental toxins. Maybe your lifestyle hasn't been very conducive to health. All of those things add up. And so as we get older, we are more at risk for developing pathology. So a lot of cancer screenings start after age 40, although pap smears for girls start in late teenage years usually, and are recommended every 3 to 5 years, depending on individual risk factors. There's no screen for men starting early on. So then starting at 40, 45, you might start doing colon screening. Mammograms for women start in 40s, and then men start doing colon screening in 40s as well, 45, 50. PSAs start for men, checking the prostate later on, although there's a lot of controversy over how frequently that should be done because there is a lot of unnecessary invasive testing done. I think it's still important to know more information than to have too little information. So that's what the conventional screening looks like. From our perspective, if there's a family risk somewhere, or if you have a personal history of issues with a certain organ system, we might consider testing earlier. So for me, that looks like if you're coming in with complaints of bloating in your lower abdomen, I'm thinking, okay, this could be constipation, this could be other gastrointestinal dysfunction, this could be UTI, or it could be cysts on the ovaries. But no matter what, I want to do imaging and really see what's going on. In the back of my mind, I think about stories where I've heard people having things like bloating or pain that go untested, and then we end up finding a cancer at some point. So I don't want to paint the picture that any symptom you're having is cancer. That's not what I mean at all. It's just that if it's not on your list of something to ask, it should be something that you ask your doctor about, and it's something that we're always considering testing. Someone that's having migraines out of nowhere with no personal history or family history, we should do an MRI and really see what's going on. So I'm always thinking imaging in the back of my head when there's some unexplained symptom coming up or a symptom that's not responding to the treatment I'm giving it. That's another clue. And then there are some of these fancy tests that I mentioned earlier on in the session. We've got different blood tests for early detection. I think there's a specific question about this later on, so I'll just answer it now too. Is Grail the best test for early detection? So this comes down to different things we can detect in the blood if there's a cancer in the body somewhere. When cancer cells develop and the cells are growing and dividing, they can release a couple things into the blood. Circulating tumor cells can break off, and those can be measurable. There are little proteins on the surface of them that are kind of like little antennae that stick up, and we can do stains for them to see, okay, are there circulating tumor cells, and where is it most likely that this cell came from? So we can go looking in that spot and see if there's cancer there. That's circulating tumor cells. And then circulating tumor DNA is quite similar, except it's not a whole cell, it's the genetic material that's leaked out into the blood. So there's a couple tests. Grail, I can't remember which one of those two things that Grail is looking for, but it's looking for one of them. And what I've seen in the research with Grail is that it's better at detecting early some of the cancers that we don't have screens for. And it's not very good at detecting the most common cancers. So most commonly breast, prostate, it's not very good at picking up on those. Whereas it is good at picking up on gallbladder, liver, hepatocellular carcinoma, and various other cancers that we don't have screens for. So Grail, there's certainly a role for Grail in just a basic test to see if you have something, if you're up to date with all of your other screens. I don't think it's enough on its own if that's the only thing you're doing for cancer screening. There's another company, RGCC, that we work with. They do circulating tumor cell testing, and they can pick up on circulating tumor cells from cancers of different origins. They don't have the ability to pick up on anything that came from brain. So that can be a limitation if that's something that we're suspicious of. There's another company we just are beginning to work with called DATAR, DATAR. And they've got, it's interesting, they have a cool panel where if you're suspicious of something, a lesion or something in one part of your body specifically, maybe you have a tumor marker that's elevated or you see something suspicious on imaging, you can do this DATAR test and say, I want to know about cancer in that tissue specifically. And because it's only looking for one kind, it's quite accurate, sensitive and specific for picking up on it. So that's useful for that. They have many other panels too that we can use for various stages in the cancer journey. So those are the best early detection type options for blood test goes. Here we do a lot of bioenergetic testing too, that assesses the health of acupuncture meridians and overall voltage. So we don't tend to think of ourselves as being electrical beings. We don't go near light sockets. We don't need to plug into anything to charge. So we don't tend to think of ourselves like that, but really the way that every cell communicates with each other, the way that our muscles work, our nerves work, is all electricity. It's a gradient of electrolytes across the membrane of your cells that create a membrane potential that can fire. It's like your nerves firing in your brain. So think about an EKG, it's measuring the electricity of your heart. The EKG of your heart's measuring its electricity. And then the EEG of your brain is measuring the electricity of your brain. So that type of electricity is present all throughout us. That's why we have an electromagnetic field. So every part of our body is going to have its own energetic strength, and systems that are weaker could be more susceptible to cancer. So we're always looking at everyone's different systems with the bioenergetic testing. Sometimes that could be an early sign that there's weakened organs there. That was a very long answer to that short question, but it's not so simple. We like to do very comprehensive screens for everyone and pursue every symptom until we've made sure to really test it thoroughly. So the next question I have is about hyperthermia. How does hyperthermia work? So hyperthermia is technically a form of radiation. Radiation simply means a transfer of energy from one spot to another. In the form of radiation that you hear about for cancer care, that's what we call ionizing radiation. It's a specific wavelength that causes damage to the DNA of the tissue that's being radiated. Other things that cause ionizing radiation are certain spectra of the UV light from the sun. That's why getting too much sun can be hard on the body. Also things like microwaves. That's not how radiation for cancer works, but just to paint the picture of what that means. There's other kinds of radiation, which is maybe just the transfer of heat. And that's what, in this context, I think the question means, how does hyperthermia work? So there are less or non-harmful wavelengths of, there's non-harmful wavelengths of energy, such as ultrasound. that as the energy is being transferred into the tissue, it doesn't damage DNA, but it can maybe heat the tissue up. So ultrasound, therapeutic ultrasound, for example, or different spectra of infrared light, those heat the tissue. If the tissue gets hot enough, you create an environment where the proteins can break down, and cancer cells are particularly susceptible to this. The body makes something called heat shock proteins. This is what happens when you have a fever. Your body heats up, the heat shock proteins are made, that activates your immune system and also works to kill viruses, cancer cells, etc. It's really interesting on that note. In October, I attended a conference. It was the Advanced Applications in Medical Practice, the 2023 fall one. It was in Arizona, and it was oncology focused. And we heard a lecture about fever, actually. And there was some interesting data being presented about how it was just observational. They just asked patients that were diagnosed with cancer and compared it to healthy populations. People that had less fevers in the past decades, maybe 1 or 0, instead of the 3 or 4 that the healthier counterparts had, it just showed that the fever actually had protective effects, and a body that was capable of producing fever had the vitality in it, and maybe the fever itself killed early stages of individual cancer cells here and there. So kind of interesting to consider. Our society tends to be a little germophobic. Some exposure, some education of your immune system with exposure to viruses, bacteria can sometimes be helpful, as long as you're not sleep deprived, chronically stressed, nutrient deficient, anything that would make that illness too hard for your body to fight off. I'm not saying go get sick. It's just interesting to consider. So back to hyperthermia. When we're using it in a medical setting, the idea is to heat up the tissue enough to kill cancer cells. In the United States, this is available as local regional hyperthermia, meaning able to treat one part of the body at once. In other countries, they do whole body hyperthermia, head sticking out of something and then your whole body getting hot. Some of the nuances to the conversation involve how hot is the tissue. It's important when we're thinking about cancer killing effects in hyperthermia, the tissue has to get hot enough that the cancer cells are killed. If there's a little bit of warming up of the tissue, but not enough, sometimes in theory that could increase vascular growth to the area that wouldn't be helpful. So really it should be under the guidance of a medical professional who's using technology that's sophisticated enough to heat the tissue enough. So that's an important thing about hyperthermia. One of the doctors we've been referring to, they're local relatively, although they are in Santa Monica. We refer cancer patients there for a pretty sophisticated heavy-duty hyperthermia using therapeutic ultrasound in conjunction with low-dose radiation. Well, all radiation is low-dose or fractionated, but in conjunction with radiation or chemotherapy, including the fractionated chemotherapy that we do here, we get a very synergistic effect. The cancer is being destabilized by radiation or chemo, and then we add hyperthermia to get it from the other side, and we have a stronger effect together. As far as other applications of hyperthermia, we've seen it maybe make a tumor more susceptible to other cancer-killing strategies. It's really helpful for cancer-related pain in a lot of instances, so thinking more palliatively and helping people tolerate their other treatments. And then it's also can be used for more benign conditions. I'm thinking benign prostate hypertrophy. I don't think we've done it here yet, but I know it can be used too to help with vaginal atrophy related to menopause, so vaginal dryness or pain with sex. It helps increase blood flow and stem cells in the area to try to regenerate or support that weakened tissue. So we could think of it like that too, as adding vitality to the system. Okay, so I hope that covers hyperthermia. How long is treatment at the center? So that really depends on what your goals are, what we decide based on all the test results that are coming in, and then also how treatment is going. So if you're here for cancer and you're already through all your primary treatment and you want to just see how your body's doing, get all the testing done, we might recommend a week or two. That gives us enough time to do all the testing and try out some of the treatments. Based on the results, which can be reviewed at a remote consult, we might recommend that you come back to work on some of the imbalances that we found. If you get here and you have a later stage 3 or 4 cancer, maybe we recommend that you be here at least a couple days a week for several weeks, at least until we get the initial testing done and the follow-up testing done to see how efficacious the treatment was, make sure we're hitting our goals. The last thing we want to do is say, oh, you only need to be here for 3 weeks and then we'll send you off, and not get the follow-up that we need to make sure that everything's working, and that when you go home, you land back in a team that can pick up right where we left off. So there's a lot of nuances to it. We don't have the opportunity to work directly with practitioners in other locations, but of course we have to do what's best for you. And if you can't be here for a long time, we're going to make our recommendation and then figure out a way to support you from afar. So that's definitely very malleable. From a center side perspective or non-cancer perspective, it also depends on what we're treating. Something like chronic stealth infections, I'm thinking Lyme disease, or neurodegenerative diseases that have a Lyme component or a mold component, those can take a long time. You can't really push the body to detox or to kill some of that bad stuff quickly, because if you do it too quickly, you get a lot of side effects. As those things die, they might release a lot of toxins, you might get a flare of symptoms, and it just doesn't work. It's not tolerated. It doesn't work. So we try to send you home with as much of a home plan as we can, but also we might recommend that you be here long enough to get a good treatment in. And that can look like anything from 6 to 12 weeks, depending on what it is. Or maybe you can only do 3 weeks initially, and then we follow up remotely and plan for the next visit. There's a lot of wiggle room there. But we're not done treating you until every single symptom you have and complaint you have and abnormality we find is gone. So we'll always figure out a way to follow up on all those loose ends. So the next question is, how does hyperbaric chamber work for cancer? I want to start by talking about what hyperbaric is for those that don't know or haven't experienced it. So it's a chamber that's airtight that you sit in, and the pressure is increased in the chamber in a way that forces the air that you're breathing that's then in your blood to go deeper into the tissue. So it increases the oxygenation of all your tissue. That's the short answer. One of the ways that it's used conventionally is to help people that have been experiencing the bends from scuba diving, coming up too fast. They put them back under pressure to get more oxygen. And then in the oncology world, they might use it for healing, helping patients heal from radiation burns. So we've used it in that way too. Otherwise, in more integrative settings where it tends to be used more often, it's amazing for mental health. It can help with blood sugar and lowering that. It helps with any traumatic brain injury or Alzheimer's, cognitive decline of various kinds. It can help with wound healing. So I recommend it a lot in pre and post-surgical settings. When we need more oxygen, it's because oxygen is the most important nutrient in the energy production of the cell. For a cell to regenerate, for tissue to heal, it needs oxygen. So that's not going to happen in a low oxygen environment. That's why anything that has inflammation, cellular damage, like surgery or chronic inflammation, will all benefit from hyperbaric oxygen. So for cancer, or I guess in a healthy setting, in your healthy tissue or non-cancer tissue, what we expect it to do with the increased oxygen is create healthy vascular growth, regenerate and grow tissue, and support healing. So that the question comes up, well, how safe is that in cancer? Because isn't that the opposite of what we want in cancer? Cancer has too much blood support and it's already growing too fast. We don't want to add to that. And so the short answer, the simple answer to that question is that the pressure and the higher amount of oxygen is going to behave differently in cancer tissue than in your healthy tissue. And that comes down to mainly a really important protein called hypoxia-inducible factor. Before you've had cancer, in that tissue that's beginning to be abnormal, one of the issues happening in that inflamed, imbalanced, hormonally imbalanced tissue is low oxygen delivery. When there's low oxygen, hypoxia-inducible factor forms, and that stimulates blood growth to the area to try to fix the tissue. And then cancer cells that may be developing there say, hey, I realize that when the oxygen's low, I actually get more blood supply and more things that I need. Not to mention, I don't like using oxygen for my metabolism, so I actually like this hypoxia-inducible factor. When oxygen enters the system where HIF, hypoxia-inducible factor, is acting, when oxygen goes there, it degrades the hypoxia-inducible factor. So it actually turns off those processes that are leading to that perpetual stimulation of vascular growth. There are other things that can cause that, but low oxygen is the main driver because of that HIF. So your healthy tissue doesn't have the HIF like that. In those tissues, the hyperbaric is providing the oxygen that's needed for healthy tissue. In the cancer tissue, the oxygen is degrading the HIF, which decreases the cancer's ability to recruit vascularity and replicate and grow. So the answer is hyperbaric will behave differently in your healthy tissue. It's helpful for a healthy tissue. In your cancer tissue, it's actually turning off some of those processes. So when it comes to cancer care, though, there are some considerations for when hyperbaric is appropriate. There are various contraindications, conditions you can have that might not make it safe. Some of the top ones that come to mind are having compromised lung or risk of lung collapse because of the pressure in the system. And there's some others that we can talk about if we have a consult. The other thing that comes to mind is type of chemotherapy. So when you're doing hyperbaric, because of the pressure on the system, that can influence how quickly your body's processing different drugs, either making you not process them as fast. In other words, that drug is building up in your system and causing more side effects, or making you process the drug too fast, thereby making the drug ineffective. So the main chemotherapy that comes to mind that's a big no-no with hyperbaric is bleomycin. Some other ones that we're cautious with are doxorubicin and then the platinum drugs, although I've also seen evidence that the hyperbaric's actually synergistic with platinum drugs, and it is synergistic with several other chemo drugs. So if we're considering using it, which drugs are you using, and when do we want to do hyperbaric in relation to them? If it's been weeks to months since you've had the platinum drugs, then there's no issue. If we want to do it in proximity, which drug is it? Is there any evidence that the hyperbaric's affecting the effectiveness of the drug? We have to watch very closely. Okay, that's my other long answer to that question. And it's kind of related to this next one. So please explain how hyperbaric or ozone treatment of blood can increase oxygen in cancer cells. If it's useful, please explain optimal treatment. So I just explained how hyperbaric works. Ozone is another oxygenation technology that we have available to us. The air that we're breathing, the oxygen, is two oxygen molecules bound together O2 is what it's called. Ozone gas is O3. So the machine takes O2 that we're breathing and adds an extra one to it. So there's 3, and that's ozone. It's very unstable. So when we make it, we have to use it right away within a couple, 5 to 10 minutes or so optimally. When O3 enters the system, a simple way to think about it is that that third oxygen molecule breaks off, and we're left with O2, which is oxygen, which gets used for exactly the way that the body normally uses it. And then we have this singlet oxygen, which basically I think of it as bouncing around until it finds something inflamed to bind to and calm down, or it finds a virus, bacteria, cancer cell, bumps into it and can help treat it or kill it. And so within a cancer cell, or in the context of cancer in general, some of the things that we think about it doing, because it's oxygenating, are improving chemo and radiation sensitivity. It can be energizing and helping patients tolerate side effects of their cancer treatments. It does increase tumor oxygenation, so we're thinking about reducing that hypoxia-inducible factor we were talking about before. And then it increases the body's natural antioxidant production, which, when it comes to a prevention standpoint, hyperbaric and ozone, by increasing our antioxidant status, we're reducing inflammation and giving the cells the tools that they need to go find suspicious cells and kill them, or turn them back into normal, or whatever the mechanism is that it's going to use. And then the ozone itself, when it encounters cancer cells, can kill them. So that's kind of the spectrum of ozone. As far as the optimal application goes, that's a pretty nuanced question. More oxygen tends to be better. In the case of ozone, maybe more so than hyperbaric, but with both, we have to consider it. They can temporarily increase oxidation or inflammation, and then the net rebound effect is anti-inflammatory. So you can have too much of it. And one of the ways we think about that as evidence is hyperbaric is very synergistic with vitamin C. You can have someone do a lot of vitamin C every other day or so, every day, and do really well with it, doing hyperbaric on its own every day, every other day. But when you do them back to back, that's when we can see side effects of like, whoa, now they're really tired, having symptoms of too much oxygen. So it's okay to do them back to back. It's very synergistic. It increases the effects of both, but that just goes to show that the hyperbaric and the ozone can actually add oxidative stress to the system. So just something to think about. But we do, in patients that it's indicated to use hyperbaric for, indicated and safe to use hyperbaric and ozone therapy for, we recommend one or both of them at least once a week. It's kind of a standard. Okay, the next question: for postmenopausal breast cancer that is estrogen positive, progesterone positive, and HER2 negative, the Ki-67 is 45% and the grade is 3. It was 15 millimeters, invasive ductal carcinoma, and was removed with clean margins. What would you suggest besides aromatase inhibitors for support or an alternative? Okay, there's a lot there to unpack. So postmenopause, I'll just go, piece by piece and kind of tell you some thoughts about it. Postmenopause, we're thinking your body's natural production of estrogen has dropped. Most women I test to undetectable levels. Even in those cases, a consideration for aromatase inhibitors is put forth. Those drugs block the conversion of testosterone to estrogen. Even if your body's making a low level of testosterone and it's not even converting to a measurable amount of estrogen, at least as detected in the blood, the blood's not totally reflective of what's happening in the breast tissue, or in, if we're talking about an endometrial cancer, in the reproductive tissue. So sometimes hormone blocking drugs are recommended even if the hormone levels are undetectable in the blood, because the tissue itself could have a higher burden of that hormone. So post-menopause, you simply block the conversion of testosterone to estrogen. Therefore, then the estrogen is not there to bind to estrogen receptors on cancer cells. So in this case, I want to point out that the patient wrote very estrogen positive, meaning when they did the test on the estrogen receptor, the histologist or pathologist gave it a score of 95%, meaning you can't go higher than 100%. And then the progesterone receptor was only 60%. I want to point out that if something is estrogen receptor positive, it is way more likely than not that the hormone suppression will be helpful, regardless of if it's very or moderately estrogen receptor positive. If it's positive, a hormone blocker should be considered. Okay, then we go into HER2. So HER2 is a protein on the cancer cell that can make it a lot harder to treat if it's there. Hers was negative. Fortunately, these days we have multiple drugs that can target HER2 for HER2 positive cancers that would be considered in a case like this if it was HER2 positive, which it wasn't. Next is the Ki-67. So Ki-67 is what's called a proliferation rate or index. So when their pathologist they do a special wash on the cancer cells when they do the pathology, and they're saying basically how replicative or how much of the cells are replicating. It correlates with how quickly growing it can be. A low number is considered under 10. 15 is kind of borderline. Over 15 is considered high. So this individual would have a high Ki-67 at 45%. Some of the highest I've seen are 90. I've even seen 100% twice before. Those would be very quickly growing. So we have to watch these individuals much closer. Maybe we do our screens closer together. We recheck the blood work more frequently because things can change a lot faster. Grade 3 is based on if there's any invasion of the cancer cells in the tissue into neighboring lymph systems or vascular systems. A combination of different findings gives it a grade of 1, 2, or 3, and that also speaks to aggressiveness. The size of this was overall pretty small, 1.5 centimeters. Invasive ductal carcinoma is the most common kind of breast cancer with a more favorable prognosis, and then removed with clean margin. So I'd be curious to see what the margins are. Pathologists and surgeons are looking for at least 2 or 3 millimeters. I would say we want at least 4, and if we can get a whole centimeter margin, depending on the kind of surgery it is, and if it's close to anything that would make it, if it's close to the surface of the skin and you can't get a whole centimeter, obviously, that's a tough situation. But if we can get a centimeter, that's great. So what do I suggest besides aromatase inhibitors? And I will say that I do recommend an aromatase inhibitor in this case because of, even though the tumor's gone, we have circulating tumor cells to think about. And there could be microscopic cells that we can't pick up on scans and blood work that we need to think about. So hormone blocking, if you can tolerate it, is recommended. And then otherwise, for support, I'd want to be thinking about, okay, the scar from the surgery, how much is that impacting your lymphatic flow in the area? Is there any residual inflammation in the area that can be treated with different lymphatic therapies or electrical therapies? Essential oils can sometimes be helpful. Systemically, we want to think about treating circulating tumor cells with IVs, things like hyperbaric and ozone that we already talked about. There's IVs of curcumin, vitamin C. We don't have it available here right now, but resveratrol comes to mind, alpha lipoic acid. There's all sorts of things. And then we're thinking about what's your immune system looking like. We're doing a lot of a certain kind of panel right now called the lymphocyte map by Cyrix Labs. Looks at all the different parts of your white blood cells, the different factions of them, like branches of the military, to make sure that we have enough of them and that they're in the right proportion to each other. But there are other basic labs you can do through Quest or LabCorp, like the natural killer function panel, or breaking down further different groups of your immune system, like the CD4 positive cells or the CD8 positive cells. Those are proteins on the surface of cells that it's kind of like, so I really tend to think of the immune system kind of like branches of the military. Within each branch, there are different proteins on the surface, kind of like badges indicating which branch the cell is in and what its special capacity is or special function is, or rank maybe. And so CD4 and CD8 are like different badges that designate different parts of your immune system. We want to make sure that those are balanced. So doing an investigation of that, and then looking at root causes and treating all of those, which I've kind of briefly touched on a few times. This next question is concerning hormone blocking. So this might be helpful considering the conversation we just had about the aromatase inhibitor. So this patient said, I had a horrible time with anastrozole, the estrogen blocker, which is an aromatase inhibitor, and was taken off of it 7 months ago. So I'm assuming this person is postmenopause or has had a hysterectomy and therefore doesn't produce hormones from an ovaries anymore. Every joint was in pain, and my right leg was so painful I couldn't sleep lying down at night, and I gained 20 pounds in 9 months. Oof. Okay, so you definitely had a hard time with this. I don't often see that level of intense side effects, so that's definitely on the stronger side. And then they commented that their weight went back to normal. I don't want to take tamoxifen since it's known to cause other cancers. So let me touch on that so we can compare this other type of hormone blocker. This is called tamoxifen. It's the most common one that I see in this category of drugs, called selective estrogen receptor modifier or modulator. It turns out that we have estrogen receptors in every cell in our body for the most part. And the ones that are specific, they're ones that are in the breast tissue, look different than ones elsewhere in the body. This medication blocks or dampens the effects of the estrogen receptors in breast tissue, but it still allows for stimulation, or it can even add stimulation to estrogen receptors in other tissues. So it can stimulate bone, brain, heart. What I think of most often is the uterus, because one of the one of the side effects that we want to screen for and be mindful of is that it can stimulate the uterine lining and cause the uterus itself to be enlarged. So any patient that I'm monitoring right now that's on tamoxifen, I do periodic pelvic ultrasounds to make sure that that's not happening. So tamoxifen is therefore useful if someone is premenopause, or if they have a risk of something like osteoporosis. If you take that first drug, anastrozole, which is blocking estrogen production overall, then your bone loses its support and you can get low bone density. The tamoxifen might be better because it actually is adding estrogen support to that area and only blocking it in the breast tissue. So that's because, though it's stimulating some tissues like the uterus, it's been associated with increased risk of endometrial cancer and uterine cancer. So that's a trade-off. There's trade-offs to all of these, unfortunately. So this patient then added, I'm taking Estro Focus, which has indole 3-carbinol in it, and DIM. DIM is diindole it's related to the I3C in that it's two of them together in it also. So she's taking both. And that supplement, it's one of the extracts from our broccoli sprouts and other foods, actually stimulates the detox of estrogens from the body. So in a way, it can help lower estrogen and allow for healthy estrogen processing. And I'm also taking artichoke extract, which promotes healthy estrogen metabolism. So again, helping to break down excess estrogens. And artichoke, interestingly, it can have, this brings up a conversation about what we call phytoestrogens, which are molecules from plants that actually look kind of like estrogen in the system. So the way that I think about it is, I'm going to use my hand as a kind of a, and for people on Zoom here, this is an estrogen receptor and over here is the cell. When estrogen binds to it, we get this chain reaction of growth, support, division, where in a healthy cell that's really helpful, but in a cancer cell it leads to growth and division and stuff that we don't want. So estrogen binds like that and has that strong effect. Whereas plant estrogens, I think of as more kind of coming into the receptor and modulating it a bit, stimulating it to a degree, but in a way that actually in a lot of the big research has been shown to occupy the receptor in a way that the estrogen itself can't bind. So some of the big research you see on flax, for example, which is a phytoestrogen, or soy, although there can be really bad sources of soy, so you have to be careful with that one in particular, shows that the phytoestrogens are helpful if there's an estrogen dominance in the background that you're blocking. The phytoestrogens also help to, because they gently interact with the receptor, they take the edge off or help minimize low estrogen related symptoms because they're adding a little bit of stimulation. So it's a little controversial in that if you're taking too much phytoestrogen and you don't have anything blocking the receptors, sometimes that can create a result that we don't want. That can be too much estrogen stimulation, or it can naturally raise your estrogen. And then sometimes, especially in the context of very low natural estrogen, it might be helpful. Or if there's an estrogen dominance and it's blocking, it's really case by case and we have to watch closely with labs. So then the patient said, my pain since the anastrozole was stopped is manageable with massage and physical therapy. I can sleep and I'm hoping to get back to normal. Any suggestions? I think it's clear from the research that the hormone blocking medications reduce risk of cancer recurrence. So my typical recommendation is to do those if and when possible, and to try ones that you haven't before if other ones don't work. That being said, for some patients, they're just completely intolerable, or they're on them for 2 years and now having low bone density and some other health concerns. In those cases, it's like you've done the best you can and you followed the advice as best you can. If you can't tolerate it, then we have to do the best we can without them. And so the I3C and DIM in artichoke, I'm sure they're helping you feel better, and they're probably adding more balance to the hormones than you would without them. We'd want to double check on what the hormone levels are looking in the blood, if they're measurable enough to get any kind of picture about that. But I would want to have another conversation about the other hormone blocking options at that point. And then look at other risk factors like your bone density, do an ultrasound of the uterus, see if you could be more at risk using some of those other medications or if you're a good candidate or not. Okay, the next question. I had a lumpectomy for breast cancer, which was lobular. So that's the next most common type of breast cancer. This one was lobular and ductal, the size of a Tic Tac, which is impressive that they found it that early, although I see why now. It was only detected with MRI and couldn't be seen with ultrasound. So to comment on that, different breast imaging options have different strengths and weaknesses. Ultrasound can see through dense breast tissue, which mammogram can't see through very well. So ultrasound's helpful if you have dense breasts. It's also helpful at detecting if something is more solid or more cystic, fluid-filled. But it doesn't have as much resolution. It looks a little grainy. You can look up pictures on the internet of breast ultrasounds and see it kind of looks like, radar machines. It's not always so clear what we're seeing. So that's a limitation. Mammogram, as I mentioned, can't see through dense tissue very well. So if you have dense tissue, you should always ask your doctor, and I always order an ultrasound to follow up on it even if it's normal, we think about doing it every once in a while. And then if the mammogram's normal, we think about doing the ultrasound too, because the dense breast could be hiding something. Then the mammogram, however, is pretty good at seeing calcifications, which are difficult to see on other imaging types. Thermogram isn't mentioned in this question, but I do get questions about it a lot. Thermogram picks up on vascularity and heat, which can be signs that something is wrong. Sometimes something that's wrong is cancer, but other times it's increased vascularity, hormone imbalance, iodine deficiency, and a number of other possibilities. Maybe you strain the muscle there, maybe you have bad lymph circulation, stagnant lifestyle. So if the thermogram's abnormal, we have to do one of these other tests to follow up on it and see what's wrong. And if those other tests are normal, it means some of the heat and vascularity we're seeing in the thermogram, we should still work on trying to fix, because heat and vascularity, too much of that activity could be underlying or, years before a cancer could develop in that area. And then an MRI is one of the more resolute pictures. It can see with a lot of detail the differences between neighboring tissue structures. So it makes sense in this context, if it was the size of a Tic Tac, why that was the only imaging type that picked up on it. So then the person said that during the surgery, they got it all and it was within the borders. So I think that means it had good margins, and we talked about the optimal margin sizes earlier. There was nothing in the lymph nodes, and this patient is doing RGCC every 6 months, and it went from 7 to 2.5 with all their recommended supplements and cytotoxics. So for the context of what I have seen with RGCC tests, most patients are starting between 2 and 4 cells per milliliter, or per 7.5 milliliters for breast cancer. And so 7 is quite high for that being a starting point, and for you only having the size of a Tic Tac. So it's very good that it came down into that more common 2 to 4 range. And RGCC lists under 5 as being the reference range for under 5 is lower risk, and over 5 is at risk or concern for things growing and spreading. So the question then said, so something is swimming around in me. Yes, unfortunately, when the cancer process has initiated and a cancer cell forms, that process is very perpetuating. The cells grow and divide, and it's usually growing and dividing cells that are susceptible to chemotherapies, IVs, etc. Sometimes cancer cells go into dormancy mode in tissue and hide, and they're just difficult to detect by the immune system in different treatments. So I want to use this information to empower us that when you've gone through your primary cancer treatment and there's no evidence of disease, we still have to be thinking about the unmeasurable disease. We have to be thinking about what's going on energetically in that tissue, and is there a level of circulating tumor cells or that RGCC can maybe pick up on, or that maybe it's not picking up on, that we just have to suspect is there. And that should empower us to always be making our healthy choices in our lifestyle and following up with our doctor. And then the question said, it was estrogen and progesterone driven. Thoughts? If you need further info, you'll get it to me. Okay, I think that might take a consult so we can really dive in. Again, I want to say that as far as RGCC test goes, 2.5 is low. I usually try to get people down to 2 or under 2, but 2.5 is a good place to be, considering it was at 7 before. Question is about, this patient is hoping to get some clarity around non-melanoma skin cancers. So I had melanoma at age of 20 that was removed. I'm now 42, and in the past 5 years have had several basal and squamous cell carcinomas. Are these skin cancers also able to be prevented with diet lifestyle changes, or is it different since they are caused by sun exposure? Okay, so when we're thinking about, again, it comes down to what are the risks for this cancer and are we addressing them fully? Can it be prevented means, have I mitigated as much risk as I can, and then given my body the tools it needs to heal, find, minimize these cancer cells. When we think about cancer risk, a lot of people say, well, isn't it just genetics? Didn't I get my risk from mom or dad? And I want to point out that genetics only drives 5 or 6% of cancer, meaning you're born with a mutation that makes you susceptible to developing cancer in the future. Cancer is an accumulation of mutations that you can be born with. Well, that's only 5 to 6% of the time that in cases of cancer. Otherwise, what else could be mutating your cells? As you get older, as I mentioned, when your cells divide, there are errors that happen in that. That's normal. I learned from a PhD researcher at City of Hope. This was a cool lecture I attended. Dr. Tomasetti told us that every time a cell divides, 9 billion base pairs of your DNA have to replicate and on average, there's 3 errors. So every time your cell replicates, which over your lifetime is quite a lot, although it slows down after the warranty's up at 40, which we talked about at the beginning, every time the cell divides, those errors happen. If it happens in the part of your DNA that's not crucial to the function of that cell, then it can be very silent. It is totally inconsequential. If it happens in important spots in genes, now the cell can start to behave abnormally. Now a cancer can develop. So when I think about skin, of course, we think about the sun. Our skin is exposed to the sun typically, although more and more now we're inside and not getting the healthy amount of sun that we need, because there is a good amount. The sun has a subset of ultraviolet rays that have that ionizing radiation in it that we talked about that can damage the DNA. That's why too much is not great. Or if we have a lot of sun exposure, we want to increase our antioxidants. So leafy greens, other dietary things, berries, things like resveratrol and glutathione, and those antioxidants help minimize risk associated. And taking those things, especially if we have like a sunburn, is important. Sun is one of those things, those particular ultraviolet rays can increase damage to the DNA there, increase risk of skin. But with skin, I'm also thinking things that we're putting on our body, lotions that have toxins in them, the clothes that we wear can be made from plastic, have flame retardants in them that, of course, we don't want the clothes to be flammable, but I think there's a pretty low risk of our clothes. On a regular day, our clothes have low risk of catching on fire, so it's too bad that they manufacture them that way for all of us that wear those products. There are other exposures, pesticides, I'm thinking of plastics, all of those things. When your liver isn't able to get rid of those things in the moment, or your kidney or your stool, your body puts it away. It's like shoving the laundry under the bed when you don't want to do it. Put out of sight, out of mind, but that thing there can create problems. So with skin, we're thinking environmental exposures. Always we're thinking dietary, cancer like sugar. We want to minimize or eliminate alcohol, as that can be carcinogenic. The skin also benefits a lot from antioxidants. So can we find replacements to our products that we're using that also have antioxidants in them? A lot of herbs are high in antioxidants and vitamins, so we might think about making those switches. Okay, I think we've come to the end of what we have time for tonight. I want to stop and move to the end of the slideshow for a moment to just pull up. Actually, since I don't need to do it, Cindy, who's in charge of our social media, was telling me that if I go like this and say that if you want to learn more about how to contact the center, you can click right here and she will drop a link on the screen. You'll be able to click on it and find the contact information to the center. The website is the Center for New Medicine. There's also one for Cancer Center for Healing. The respective phone numbers are on those websites as well. so you can follow and learn more about how to get in touch with us. I'd love to meet you and hear about your health journey, see how I can intervene in any way to help you prevent cancer, screen for cancer, get your diagnosis if you're suspicious of anything, help you through the initial treatments, help you through the final ends of the treatments, and then help surveillance you at the end, and then, fix all the root causes. So any part of that journey, I'm happy to help and dive in. Good to be with you all tonight. Again, I'm Dr. Ptak. This is the Cancer Center for Healing and the Center for New Medicine, and we'll talk to you in 2 weeks. We have our next cancer conversation. They're every 2 weeks this year. One of them a month is the Q&A, which I think is this first or second Tuesday of every month. And then the second one is going to be a guest that's invited every month to talk about a topic in detail so you can get more specific information. All right, good to be with you and have a good night.